So again, welcome to everyone. Thank you so much for joining us on this webinar today, Creating an Audit-Ready Patient File for O&P Claims. Again, my name is Maggie Baumer. I'm the president of the National Association for the Advancement of Orthotics and Prosthetics. And I'm joined today by several speakers. Our first speaker is Peter Thomas. He's the General Counsel for the NAAOP and also the Managing Partner at Powers, Piles, Sutter & Burville in Washington, D.C. We also have Ann Moss, who is the Vice President of the NAAOP, and she is also the owner and president of Union and Delatory O&P in Pittsburgh, Pennsylvania. We're also joined by Kevin Symms, who's a board member of the NAAOP and the owner of O&P Serve Consulting. And finally, we also have our 2022 George Breece Fellow, which is Nikki Grace-Strader, who will be giving us some final comments towards the end of the webinar and telling us a little bit more about the fellowship and her participation in the fellowship. So with that, I'm going to get started. This is an overview of today's discussion. So there are several key points we're going to hit on. The overview of the audit environment is going to be done by Peter Thomas. And then we'll move on to creating an audit-ready patient file, which is going to be spoken to by Ann Moss. And then finally, documenting medical necessity effectively is going to be done by Kevin Symms. And then we'll have some time at the end of the webinar for some Q&A, as well as some parting comments. I also want to make sure that everybody is aware that this particular webinar is a complimentary service to our members, and we'll also be having a second webinar on June 14th. And we're joined today by other people outside of the membership, and we thank you so much for joining as well. Just to let you know, you can join the NAAOP and become a member by logging onto our website at NAAOP.org. You could also email us directly, and we'll provide our email information in the chat. So with that, I'm going to hand it over to Peter Thomas, who's going to talk about the overview of the audit environment. Peter?
Thank you so much, Maggie. I very much appreciate it. When Maggie became president of the NAAOP, we sat down, George Breece, the executive director, and Maggie and I sat down, and then we ultimately talked with the rest of the board about what we could do to benefit our membership. And one of the main areas of focus became how do we make sure that people really understand best practices for submitting claims, not just to Medicare. And of course, we'll be really speaking about Medicare to a large extent today, but also to talk about the impact on private insurers, Medicare Advantage, other kinds of claims that may be submitted for the patient population that folks serve. So we conceived of this two-part series webinar to really go through the audit environment, the appeals process, and the like. Let's get started right away. Many of you may have been exposed to a lot of these denials over the course of the years of your practice and probably have a pretty good understanding of much of what I'm going to be talking about. Since this is 2 solid hours of content, we did want to start with some pretty basic information up front. You're probably not going to learn all too much in the next several slides, but it will help set the framework for what we're going to be doing. And to anyone new to the field, of course, perhaps this will be new information that you can take and tuck away. Let me start by saying that the federal government expends tremendous amounts of dollars on Medicare claims every year, and part of their responsibility to the American people, frankly, is to audit and to make sure that they're paying claims that are appropriate and that they are not overpaying and they're not being ripped off by unscrupulous providers and claims being submitted to the program. So over the years, Congress and the Centers for Medicare and Medicaid Services, commonly referred to as CMS, have come up with a number of different mechanisms to process claims and to oversee the propriety of those claims, to make sure that they're paying appropriately. Now, Medicare uses what they typically will refer to as a pay and chase model, where they will pay the claim that comes in. It's typically an automated claim where you have miscellaneous codes. It may very well and often does go to a specific individual review of those claims. But in most instances, Medicare DME contractors, DMEPOS contractors, stands for Durable Medical Equipment Medicare Administrative Contractor, or DME MAC. There's 4 of them regionally. They are the ones responsible for not only creating local coverage policies and administering the DMEPOS benefit, of which prosthetics and orthotics is included, but also processing claims and making sure that people providers are paid appropriately for the services that are under their jurisdiction. There's a whole series of other entities that contract with the Centers for Medicare and Medicaid Services to perform various aspects of paying O&P claims and making sure that there is integrity behind those payments. Number 1 is the qualified independent contractors. Those are entities that have some clinical expertise. They are typically the second level of review in the appeals process. Once a denial is issued by a Medicare administrative contractor or a DME MAC, a redetermination will be filed. That's the first level of administrative review. The second level is the reconsideration stage. The third level is the administrative law judge stage. But the qualified independent contractor ultimately is the second stage of review, and they review reconsideration requests. There are also contractors known as recovery auditors, or what commonly people refer to as RACs, recovery audit contractors. Those are entities, private companies that have contracts with CMS to review claims and to deny claims that they don't feel are either medically necessary and appropriate or are documented in such a way as to demonstrate medical necessity. So it's not just that the claim is medically necessary, it needs to be documented in such a way that you can demonstrate and prove that it's a medically necessary claim. There are also supplemental medical review contractors, or SMERCs. Those are entities that contract with CMS to do additional claims review in a wide variety of areas. The Unified Program Integrity Contractors, or the UPICs, are additional contractors that principally focus on fraudulent and abusive activities. So where there's a referral from a MAC, where the Department of Justice or the Office of Inspector General will signal that there's an uptick in claims for this provider or these provider groups, typically the Unified Program Integrity Contractors will look at those claims. So if a UPIC knocks on your door, it's typically a more serious investigation or a more serious problem than it would be if a regular MAC did a post-payment review, or if a SMERC knocked on your door to review a sample of claims. In addition, there are CERTs, the Comprehensive Error Rate Testing Contractors. These are the entities that determine error rates for various types of providers. So the error rate for inpatient rehabilitation hospitals versus the error rate for home health agencies versus the error rate for prosthetic and orthotic providers. Error rate simply is the percentage of claims that is deemed to be unnecessary or non-payable when in fact those claims have been paid. And then finally, the Office of Inspector General. That's a different division under the Department of Health and Human Services than CMS. And they oversee and look at and examine and investigate and ultimately write reports on all types of provider activity involving reimbursement. Okay, to move on, what is the interplay between CMS and these MACs? Well, CMS is the federal agency, and they have a significant budget, and they hire these MACs, which are ultimately private companies. They typically are health insurers that have spin-offs or offshoots of their main business, and they're awarded based on a geographic region to administer Part A and Part B claims. Or to administer DMEPOS claims. As I just mentioned, there are 4 regional DME MAC carriers. They used to be called carriers, now they're Medicare administrative contractors that administer fee-for-service claims. Now, this is just fee-for-service. There's about 48% of the Medicare population that are now in Medicare Advantage plans. And those plans are administered by private companies as well, that have contracts with the Medicare Advantage program, or Part C of the Medicare program, and they provide orthotic and prosthetic care and pay for those services principally through private insurance companies. But the DME Max, as of June 1, 2021, here's a map pictorial of the different regions, and ultimately individual contractors hold those contracts for individual regions. Noridian holds 2 and CGS holds the other 2. Let me start with some very basic definitions, and this goes back to the statute, the Medicare statute, which is the highest level of legal authority. It goes statute, regulations, and guidance after that. Statute you can't really mess with. The Congress decided what these definitions are. The president signed those originally, led those bills into law, and that's what CMS must follow. CMS has the authority to regulate, but they don't have the authority to change the statute. The definition of prosthetic devices, which is different than orthotics and prosthetics, means to replace all or part of an internal body organ, including contiguous tissue, or replace all or part of the function of a permanently inoperative or malfunctioning internal body organ. Typically, these are devices such as colostomy bags and ostomy care and other kinds of things that largely fall outside of the organized prosthetic and orthotic community. I will say that most implants are also, knee replacements, joint replacements are also considered prosthetic devices under the program. Again, that's different than orthotics and prosthetics. Prostheses prostheses are defined under the Medicare statute under a different section. And specifically, they define in the statute coverage of artificial legs, arms, and eyes, including replacements if required because of a change in the patient's physical condition. So keep that definition in mind and note for a moment that really is talking about things. That's talking about devices, artificial legs, arms, and eyes, and of course, replacements. That's different than saying prosthetic care or prosthetic services. Just keep that in mind. That's in the statute. The second definition I want to bring your attention to, or I should say the third on this slide, is the definition of orthoses. They're defined by the statute as leg, arm, back, and neck braces, again, including replacements if required because of a change in the patient's physical condition. But there's some regulatory language that also helps define and expounds upon the statutory definition of orthosis. And that regulatory definition includes rigid and semi-rigid devices, which are used for the purpose of supporting a weak or deformed body member or restricting or eliminating motion in a diseased or injured part of the body. Where this has most application is in determining a benefit category when new technologies come to the marketplace. And as we all know, most O&P, if not largely exclusively L codes, the HCPCS L codes, which is essentially under the Healthcare Common Procedure Coding System, are the codes that define orthotics and prosthetics, mainly based on base codes and additional codes that are added on to the base codes. The rules of Medicare coverage are pretty clear. In order to be covered by the Medicare program, and frankly, most private insurance plans have adopted the same standard, but certainly O&P care must be medically reasonable and necessary. That's in the statute. So the term medical necessity comes from that concept. It must be reasonable and necessary, and it must be a healthcare benefit. There's a large database that can be accessed online through the CMS website, which can give all kinds of detail about what the Medicare program has determined it covers and what it does not cover. Many of those policies have been converted and have been expounded upon in the form of local coverage determinations, which are principally designed by either CMS or the Medicare DME Max in the orthotic and prosthetic space. There are also local coverage articles, which don't quite have the same impact as local coverage determinations, but they're another method of laying out what's covered and what is not covered. All of these sources are available on the CMS website, and you should look at these on occasion to make sure that what you're submitting is consistent with what the local coverage articles and local coverage determinations are saying about orthotic and prosthetic coverage. Medicare payment under the O&P benefit is for the purchase of the item. That's actually in the statute. And the statute does not explicitly mention any coverage or separate payment for O&P services. Now, this is a very vexing issue. It's a problem for the field. We've been hearing about it for years and years. We've obviously been trying to do something about it. But when the statute itself talks about coverage in terms of artificial arms, legs, eyes, neck braces, back braces, and then you've got statutory language that says that the purchase of the item is what is covered, it doesn't leave a lot of room for Medicare to cover separately the provision of O&P clinical services that are provided with those devices that are provided ultimately and delivered to patients. That forms the basis for the L-code payment system, which is a device-based payment system that is supposed to include, and when they were created back in the early 1980s, included a representative part of that payment level for the service component of what goes into creating and ultimately an artificial limb or orthosis that is delivered to the patient. It's one of the reasons, this statutory language is one of the reasons it's so difficult to be reimbursed for the services and the clinical care that orthotists and prosthetists are paid on a routine basis or deliver on a routine basis, but are included in the reimbursement level for the device itself. We have determined in following up to see whether there were opportunities to use the CPT coding system, whether you could use CPT codes. There are a couple of orthotic and prosthetic codes, along with DMEPOS codes in billing the program, but unfortunately that is not the case. O&P providers are not permitted to use the CPT codes and cannot split L codes and CPT codes in the billing of any particular device. And then finally, there is statutory language that says that O&P shall be made in a lump sum amount, a payment amount, 80% of the fee schedule amount, and then the beneficiary pays 20%. That lump sum differs from durable medical equipment, which is often reimbursed on a rental basis over a 13-month period. And it makes sense that you would pay in a lump sum because these are highly customized, individually configured prostheses and orthoses for one individual. They're not really subject to a rental model. Finally, there was some very significant statutory language that the O&P community rallied. NAAOP was part of that. AOPA and other groups from the O&P Alliance, including the ABC, BOC, and the Academy, all worked together several years ago in 2016 to get through and to have enacted language that clarified that O&P clinicians' notes, clinical notes in the patient file are in fact part of that patient file for determining medical necessity of O&P care. Believe it or not, some of the language that had come out previously from CMS had suggested that only the physician's files were relevant for the medical necessity determination. That led to a raft of denials in the O&P space. It was a major insult to the field, and it needed to be changed. Ultimately, there was legislation that was enacted to change that. The documentation now and the program integrity manual talks about documentation created by orthotists and prosthetists. And I'll just quickly read: for the purpose of determining the reasonableness and medical necessity of orthotics and prosthetics, documentation created by an orthotist or prosthetist shall be considered part of the individual's medical record to support documentation created by eligible professionals. So essentially, documentation created by an orthotist or prosthetist alone cannot demonstrate medical necessity, but it is relevant. Those notes are part of the patient's medical file. and are relevant for the medical necessity determination. And that was a very, believe it or not, it doesn't sound like much, but that was a significant step forward, and has cut off a lot of the denials that were being issued in the earlier part of 2010 through 2015. Let me pass the gavel.
Thank you, Peter. My name is Ann Moss, and I'm going to be talking on best practices for creating an audit-ready patient file. So first off, you need to collect all the payer policies. I'd start with Medicare, but I'd go through, collect your Blue Cross Blue Shield, all of the different payer policies that are published for the O&P services your practice provides. Be sure you understand all the documentation requirements that are required within the policy, both for the physician and separately for the orthotist and prosthetist. So the importance of physician records. Medicare, as we all know, will rely heavily on physician records to support the medical necessity for what was prescribed and provided to the patient for coverage. The Medicare policies have policy-specific documentation requirements built within their policies that detail specific criteria that physicians must document in their records to meet coverage criteria. So an example of this is the Afo Kfo Policy. So you can read this excerpt. There must be detailed documentation in the treating practitioner's records to support the medical necessity of custom fabricated rather than prefabricated orthosis. Now, you can see they're using the word treating practitioner. That is the physician. That's not the orthotist or prosthetist. If the orthotist or prosthetist, if you keep reading, this information will be corroborated by the functional evaluation of the orthotist or prosthetist records. So they always talk about the treating physician's records as the actual prescribing physician. So look for those specific carve-outs within policies. Some have them, some don't, but make sure you're familiar with them. So creating corporate oversight and process improvements to improve your patient records. How do you ensure your charts are going to be good enough in an audit? It's continuous monitoring. So it's just constantly reviewing everything. And it's also looking at the whole entire chart all together before you submit a claim. Because when you have an audit, that's how they're going to be looking at it. You know, you have your administrative staff reviewing this part of it. You have getting the prescriptions or the detailed prescriptions, whatnot. You have your orthotist, prosthetist looking at this part. You get the doctor's office maybe possibly sending their records. Who's looking at it all together? Because when you respond to an audit, that's what you're compiling it all together to create one picture. So create a scrub sheet or a checklist of what forms or documentation are required for each of your common devices. Medicare has a lot of checklists available online. Noridian has an excellent website. If you go under education and outreach, then tools, then they have clinician checklists that are great tools for some common items to ensure you have what you need. So the scrub sheet should include specific requirements like a prescription, detailed prescription for some of your private payers or Medicare even, if an insurance authorization is required, what the physician has to require for that particular device, and confirming signature requirements are met. I know when we're reviewing medical records for doctors, you'll get them and then all of a sudden they're not electronically signed off for some reason. You get the, or they're not dated appropriately, or they're not a valid signature. Have the orthotist and prosthetist specific documentation requirements on the scrub list. Of course, the deliveries receipt and all what's required there. Another example would be the diabetic verification for therapeutic shoes. Here's some sample checklists. On the left is a Medicare sample checklist for AFOs and KFOs. This is available online. This is just the first page of it. An example on the right is an internal document that my company uses. So we have things that, insurance approval, what's done before or after delivery, what's required by the physician, what's required by the orthotist, what the front desk is supposed to be reviewing, just all the different pieces to make sure all your I's are dotted and your T's are crossed. Educate your staff. So educate both your clinical and administrative staff on the payer coverage guidelines and the documentation needed. Medicare offers a wide range of training tools on their website under education and outreach, tons of little clips and videos in addition to these checklists to make sure they're familiar with exactly what's required. Does your orthotist and prosthetist know exactly what's required for each type of device? Is your administrative staff that is obtaining the prescriptions and authorizations and all of those items, are they familiar with everything? Assign staff to review outside clinical records. So the physician records you request need to be compliant with the payer's coverage criteria before delivery. An example was that Afo Kfo Policy. How often have we had where they prescribe, the patient clearly needs a custom AFO, but the doctor doesn't specify why custom over a prefabricated and all of the criteria, length of need longer than 6 months, all of those specifics. Someone needs to review to make sure that that is in there in case you're audited. Again, ensure the date and signature requirements are met, and educate your staff on the best practices for contacting the physician when their records are not sufficient and additional information must be documented in order for the patient to get that device. Provide education to your physicians on what must be documented in their medical records. We're just one part of what they're prescribing that has specific things they need to document. Think of all the other services that they prescribe, and I'm sure those policies all have specific things they need to document as well. Medicare has, letters to physician that can be used to educate your referral sources on the various O&P services that we provide. So those are great, coming right from Medicare to show them what they need to be documenting. Here's an example on just general medical records for the Dear Physician letter, and it's signed by all of the medical directors. Another one on the right would be the therapeutic shoes for persons with diabetes. You first read that policy and it doesn't even seem real. So this is a nice Dear Physician letter on what they are required to document. But they have ones on different orthotics, prosthetics, all kinds of different things available online. So when can items be delivered? You need to establish a company protocol for when items can be delivered the same day. An example might be a fracture. Patient needs a back brace, they have a fracture, or an emergency repair. And establish a company protocol for when items cannot be delivered until someone double checks that we have all the appropriate documentation to meet that policy. So after the item is approved to be delivered by your staff, ensure the chart is audit ready before billing. Again, assign staff in your practice to review every chart before the chart is sent to billing to ensure all the payer requirements and documentation is on file. Use your scrub sheet as a final checklist or tool to ensure your chart is audit ready before it gets billed. When you get an audit, because we all are getting them, respond timely, log your audit so you can keep track of it, be prepared to appeal, and analyze your results and communicate back to your staff on the past and failed audits. And then make the necessary improvements in your process and or documentation practices as you review what could we have done better, why did we lose this, different things like that. When an audit comes in, if your chart is audit ready before you send it to billing, you can be confident you have everything you need to respond successfully and keep your hard-earned money. I think everyone recognizes this letter is to note, this is a little blurb from a RAC audit saying a no findings determination. So this is what we all want to see. They're the thin letters.
Thank you, Maggie, and for handing over, and thank you, Anne. There are a lot of synergies between some of the stuff that I'm going to talk about with the great comments from Anne. So I'm going to get into documenting medical necessity effectively. The reality is there is maybe not a broad base of expertise across our wonderful profession in terms of how to document. I frequently hear comments like, I wasn't trained how to document, and I can't do this and I can't do that. So it is an area of focus, but it's necessary that we pay a lot of attention to it. And with a little effort, we can all improve. So the first thing that I would look at is basically some ground rules, if you like. Whatever you're doing in terms of, say, pre-authorization, etc., it has to make sense. Put yourself perhaps in the position of a medical director or a reviewer and try and understand what they would be looking for. And if you can make it make sense, then you're a long way toward achieving your objective. And part of that is to review and understand the policy. When I'm presenting on documentation, one of the first things I ask is for a show of hands of everyone in the room who have read and understand the local coverage determination. Sadly, one of two hands maybe go up, to which I would ask that should be the nighttime reading for anybody in the room. How can you document to a policy when you don't necessarily fully understand the rules? So part two is understand the rules, and then you can take part in the game, so to speak. One of the other areas that I try to focus on, and I see a lot of this, is where a clinician documents to a device as opposed to the patient. In other words, I'd like to provide XYZ device because, well, it's the best thing since sliced bread. My patient will love it. It's the latest and greatest. It's new, as opposed to documenting the reasons why that device is perhaps the one and only device that your patient would benefit from. And that kind of leads into pardon me, patient want versus patient need. I'm going to mute myself real quick. Sorry about that. Patient want versus patient need. Patients are very informed in terms of internet, etc., and they know what's available out there. So patients will frequently come and ask for the latest and greatest. And it's our responsibility to obviously evaluate those patients and in some situations actually try and make that make sense to the patient. Anticipate the questions that you might receive from a medical director in terms of your documentation. Be a little proactive. If you can, address those questions up front. I call that appeal avoidance. And if you can answer those questions up front, life gets a whole lot easier. Less is more in terms of your application to insurance. Quality over quantity. And if, again, making it make sense is a major part of this. And it's also okay to ask for help. Anne mentioned scrub sheets, internal reviews. I think it's a good idea to, perhaps when you've carried out your evaluation or put your pre-authorization document together, maybe have a colleague review it. So perhaps a little detail on some of that documenting medical necessity element. If you're looking to provide a replacement device, then describe it in detail. I tend to break it down by componentry. So if it's a transfemoral prosthesis, I would focus initially on the socket, then the knee, of course, and then the foot. So if you're looking at the socket, why does that socket require replacement? It's okay to just simply say, yes, my patient lost some weight, but do you have some measurements? Do you have the original measurements? If you don't have the original measurements for the socket that was perhaps provided by another provider, I think it's a good idea to mention that you don't have those original measurements, because then at least you're not ignoring the absence of that detail. You're acknowledging that I'm sure they're out there somewhere, but you don't have them. And then, of course, you can supplement that with other information from your evaluation. In terms of the knee, If you're looking to supply or provide say a hydraulic knee or replace a hydraulic knee, then perhaps the standard of documentation may be considered to be a little less than if you're providing, say, a microprocessor controlled knee. So again, your detail in your documentation has to match the device that you're actually providing. Feet are often an area of some focus. If you're replacing a foot, I frequently see comments like, it's going to fail in the near future, or it's showing signs of wear and tear. And I think that's okay, but could you focus and provide a definitive or a better answer or description that maybe says the device is delaminating? Provide a digital image if you can. And when providing the prescribed components, I would look to focus on the when and the why. Again, this is patient-centric and making it make sense. So during which activities of daily living is the patient expected to benefit from that particular device? And the why is why a particular component is required. And again, relate it to functional requirements. The last point on this slide is more of a hint in terms of try to stay in the pre-auth cycle. If you've made an application to insurance, and this is typically a commercial insurance, then it's easy to fall out of the pre-auth cycle into the denial cycle, and you can come back from that with an appeal, but it's more difficult. So you can stay in the pre-auth cycle by A, confirming that your application has landed with the insurance provider. That could save you up to a month, because frequently you'd call an insurance provider and their response would be, we don't have that chart, so that maybe will cost you a month. And secondly, and more importantly, when you're in that conversation with the person at the insurance provider, it's a good idea to ask, is there anything about that chart that I can help you with? Is there more information that I can provide to help you with that review? And now you're starting to establish a relationship with a person that perhaps typically is a little combative. And if you can, probably better to avoid that. Next slide, please, Maggie. Oh, you're ahead of me, thank you. So in terms of best practices, this is more of a kind of a cheat sheet for me. If you've ever had physical therapy, your first session with a physical therapist will be 60 minutes. And the reason for that is the first 30 minutes, the PT will be developing a plan of care. Frequently, patients move from patient encounter to patient encounter, and without a plan of care, you don't necessarily have a roadmap. Now, that can be a generic document that you can amend with progress or perhaps otherwise, but I would recommend it's a good idea to have a plan of care for each and every one of your patients. Recording patient weight at every visit. This is a requirement that I see rarely carried out. Two direct reasons, apart from the fact that you really should collect that detail, but in relation to replacing componentry, if you're looking to replace a socket, documenting any change in patient weight is rather useful. If you're replacing a foot, a 10-pound increase or decrease in a patient weight may take a patient out of their foot category, which could contribute toward the medical necessity requirements to replace that foot. It's also good to reference and bear in mind where your patient is in their rehabilitation. Are they on track with that plan of care? Are they doing better, hopefully, or not? And that may assist you in how you document your patient care moving forward from there. Include vocational and avocational activities. Always useful to paint a bigger picture if you can. Doesn't take forever, but it's the detail that matters. And any desired activities, that's quite useful if a patient has an aspiration to carry out or engage in an additional activity that perhaps they've never done before. Worth actually pointing it out. Home environment and family life are relevant insofar as, is there assistance at home? What does the patient actually get up to? How does it affect that person and the family holistically? Are they using ambulatory aids? If the patient is using ambulatory aids and you decide not to reference that, there might be an assumption that you've just perhaps ignored it. I mean, there are situations where a patient may use ambulatory aids as a kind of an assist. An example might be if a patient attends using, say, a single cane, perhaps in their right hand, if they're maybe a left prosthetic user, then you might be able to document that the patient uses that single cane. But I would invite you to look for opportunities to make a comment that might sound or look like patient Smith uses a single cane in his right hand. It's not an item of reliance, more of an assist in unfamiliar places, and perhaps as a visual aid to others when in unfamiliar places where perhaps it's crowded, to avoid being bumped or knocked over. And comorbidities, same. The insurance provider is aware of those comorbidities, so reference them. And it's reasonable to state that a patient is doing well or very well in spite of XYZ comorbidities. Now on to some of the further tips, etc. I would personally recommend that you avoid templates. It's difficult to document patient encounters for some folks. I've heard a lot of comments from clinicians saying things like, I'm suffering a blockage, I've got writer's cramp, I can't write one more note today to differentiate my patient from another. They all kind of fade into one. Avoid the templates if you can. I'd also avoid cut, copy, and pasting of the sales material that you get from manufacturers. It's useful, but it speaks to the device. And if you go back a couple of slides, we'd recommend that you speak to and document to the patient. Confirm your documentation meets policy requirements. It's okay to review that policy, but it's also really helpful if you can confirm in your pre-auth that specific policy requirements have been met and perhaps exceeded. For instance, if there's a requirement for ambulation of a distance greater than 400 yards on a daily basis, if your patient's walking further than that, reference it, maybe add a step count. And that speaks to differentiation of your patient. How can you make your patient stand out? And there are lots of ways you can do this. Perhaps a couple of hints and tips here would maybe help. If you have a patient that's perhaps yet to receive a prosthesis, they attend your location already moving up and down quite fluently or fluidly on, say, a walker or using crutches, then they may already be ambulating with variable cadence. You may take that patient into your examination room, and in the parallel bars, they may be able to stand for 5 or 6 minutes on the remaining limb. And that takes a degree of effort, ability, and capability. So where you can, I'd recommend that you try and differentiate your patient by adding those nuggets of information that really do make a difference. It paints that picture and will differentiate your patient. And the other thing it will help you with is when the reviewer is looking at your chart, they'll see the detail that you've provided, and it will set your chart apart. And that way it will hopefully remain on the top of the pile, and you'll get your approval really quick. A couple of last points that I think are really worth bearing in mind. If you're replacing an existing prosthesis for a patient with same or similar, perhaps because the device is just simply beyond economical repair, and you're just going with the same basic design or a repeat, then you will still need physician documentation. You will still need good documentation on your own behalf, but you might not necessarily need to spread that net too far. That's your call, of course. But if you're going from, say, 0 to hero with a new prosthetic user, and you're looking to provide perhaps a microprocessor controlled knee, then I would recommend that you might want to include the multidisciplinary team and demonstrate that it's not just your idea as the clinician, which is fine and relevant. I would recommend that you maybe include a PT, perhaps get an AMP NoPro for a new prosthetic user, perhaps involve a physiatrist, and just strengthen that documentation effort as a whole so that you're presenting the best possible case. I would typically recommend that you don't save any ammunition for an appeal. Put it all in your first attempt and give it your best shot and take the time that you need to take. And if unfortunately after all of this you receive a denial, that's not necessarily the end of the world. Sometimes no means maybe we didn't ask right. So review all of those options and ask for help. Thank you.
Thank you so much, Kevin and Peter and Anne. That was a lot of really helpful information. So we're going to move now into our question and answer phase of the webinar. I just want to say off the bat that there was a question about whether the presentation would be available after the webinar. So we are going to provide the recording to anyone who registered. I know a couple of people had some issues getting on, so we'll make sure that these are available to you. So there have been a couple of questions in the chat. Peter, I believe this first one was for you. It says, does the O&P notes that are part of the Medicare record rule apply only after the date of that rule in 2018?
Thanks, Maggie. I think the answer to that is likely yes. If you have a date of service, and by that, I guess I mean the date of delivery, after February 9th, 2018, you can most certainly use that statutory provision of recognition of the clinical notes of the prosthetists and orthotists for determining medical necessity in your appeal in challenging any denial that you receive. And should simply say that, you know, Congress determined and the Medicare law was amended on that date, February 9, 2018, that any claim for orthotic and prosthetic care that is denied, that the patients, that the clinicians or the O&P providers' notes are relevant for medical necessity and are completely viable documents to be reviewed by any decision maker determining medical necessity. However, that doesn't mean that you can't make an argument that prior to that date, those the clinician's notes, the prosthetist orthotist notes are just as relevant. In fact, CMS, you know, reviewed this issue, and we had to go to Congress to get this clarified. But our position was all along that the prosthetist and orthotist notes are relevant for the medical necessity determination. There is the counterpoint that the program integrity manual specifically said that supplier generated notes alone, supplier generated notes cannot be used as the basis for medical necessity. That is true. And in fact, O&P providers' clinical notes alone cannot be used as the sole basis for medical necessity. The O&P clinicians' notes were simply clarified in 2018 that they are relevant for the medical necessity determination. They are part of the patient's file, and they can be used to demonstrate medical necessity. So I would simply argue, I mean, after February 2018, you've got a very strong argument that whatever the prosthetist orthotist notes included in the patient's file are should be relevant for the determination. Prior to that date, you'd simply make the argument that while the law changed to clarify recognition of the prosthetist and orthotist notes, that was essentially the rule all along.
Thank you, Peter. And kind of a follow-up to that question from the same person, David. He had said they had an ALJ claim denied, and the doctor's addendum was entered 5 days after the date of service, where they had actually provided a fracture brace, which was needed on an urgent basis. And so, you know, he's wondering, it seems as though those physicians' notes were not accounted for because they were entered after the date of service. Is there anybody who could speak to that issue?
Well, I'm not aware of any Medicare rule that says that a physician addendum is not relevant after the date of service. I'd need to look at that a little closer to confirm that. If an ALJ asserts that during a hearing, you know, O&P practitioners are completely within their rights to simply say, I'm not aware of that. Can you point where in the guidance or the regulations that exists? You know, there are rules about what can be and cannot be used to deny claims. And anything that is used to deny a claim needs to be subject to public notice and comment. That's a fairly recent decision by the Supreme Court a couple of years ago. So, you know, that may or may not get under that ALJ's skin, but the fact is you have a right to determine where exactly that ALJ is getting their information. It may also be that the DME MAC may be involved in that ALJ hearing as well, and they may assert the same thing. I'm a big believer in augmenting the file to make sure that you have whatever you can use to strengthen the case for medical necessity whenever that addendum might be created. I'm also a strong believer that, and the reason is because you could wind up getting in real trouble if you create documentation after the fact to flavor the file in such a way that it lends itself to medical necessity, to a favorable medical necessity determination, when in fact that was not in the file from the beginning. If you add documents to the file, you must note that they were done after the fact, that they were inserted into the file on a specific date, and don't try to play that off as though it was in the file the whole time. That's something that can be, it could not only lead to a denial of the claim itself, but it could lead to a referral to the Office of Inspector General or some other enforcement entity for altering or in any way creating a false claim by giving the impression to the decision maker that you've added that those documents were all in the file the whole time, when in fact you've added them after the fact. So be careful about addenda, but there's no rule that I'm aware of that says that after the date of service you can't rely on a physician addenda to determine medical necessity.
Excellent,
Peter?
thank you.
Sorry, Maggie, really quick, if I could just follow up with a couple of comments. Peter, all great points. Just on the subject of ALJs, it brings a huge fear element. An ALJ is simply a conversation with an impartial person, the judge. And the judge will recognize that you're not necessarily a lawyer, unless of course you're Peter, and that you are simply behaving as the expert in the room, prosthetist, orthotist, making a case based on the documentation that you have. Do your homework and just be ready for a conversation. It doesn't have to be adversarial. And I have found that the judges in ALJs are overwhelmingly very reasonable people. So make a case and be confident in it.
Thank you, Kevin. We have another question from Rashenda, who asks about any tips for getting physicians to provide adequate medical necessity documentation. They've tried sending the Noridian checklist and the Dear Physician letter, tried sending a list of questions, and some physicians don't want to seem to provide the bare minimum. I know we've experienced that here as well. So Anne or Kevin, do either of you have any advice about that particular question?
I'm happy to take a stab unless you want to go, Anne.
Go for it, Kevin.
This is a fun, fascinating area. It takes up a lot of my time. A lot of clinicians out there, and I'm brushing with very, very broad strokes. There are some very capable clinicians and companies out there that do a fantastic job. And there are some that maybe aren't quite at that level. The reality is a lot of clinicians will take their evaluation, the book, as I call it, and send it to a physician and say, could you read that and sign it and stick a date on it, and then we're all good. Well, of course you're not. First of all, the physician loses the will to live and won't read that document. It's too long. Secondly, the physician just doesn't have the time. and you're not helping the physician, and by definition, you're not helping the patient. So if you look, for instance, let's say you're replacing an existing prosthesis for a patient, you need to cover 5 specific points in the physician documentation. Patient has confirmed their desire to ambulate or to continue to ambulate, their current functional level, expected functional level, reason to replace their existing prostheses, and also some narrative that confirms a reasonable expectation of success with the prescribed prostheses. Add to that some background on the patient and a story that makes sense, that isn't a book, and you can help a physician. Don't provide a physician with a template rather. You can provide some detail along with some guidance and assistance for the physician, but I would strongly recommend you don't put a document in front of a physician that says simply, read this, sign it, stick it in your records, give me a copy, and we're all good now. And clearly you're not. And if you'd like to add or contest any of that, please go ahead.
Yeah, I mean, definitely, you know, our orthotists and prosthetists do an eval. It's definitely easy to customize a note and just give them an excerpt from our evaluation and to ask them to include in their note. Lastly, you have to take a stand. I mean, if you have a physician that absolutely just refuses to document what is required, then you either risk not being paid or getting your money taken back in the end, or not working with that physician. I mean, it's a disservice to the patients, you know, but we have had come across physicians that just don't do it, you know. So you guys just need to make a decision for your practice and just not work with them.
Maggie, this is Peter. I know we need to move on to Nikki Grace-Strader, but I really quickly wanted to just say that is one of the reasons that it's so important to build relationships with your referring physicians and to really work on that and get to a point where they have instituted in their own office procedures without the necessity of them taking a specific amount of time out of their day, the transference of those documents and making sure that those documents are documented in such a way that that they are going to meet the standards that the DME MACs expect. They're detailed enough. They don't just list a functional level. They describe what the patient's activity levels are. They go into some degree of understanding of why this prosthetic or orthotic care is being requested.
Thank you, Peter. Yes, we do have to move on to Nikki. Just one last thing I wanted to say about the second webinar that will be happening on June 14th from 1 to 2 p.m. Eastern. It's a corollary to this webinar entitled Audits, Appeals, and How to Change Denials of O&P Care. Challenge denials of O&P care. So with that, I'm going to pass it off to Nikki to introduce herself.
Hi, my name is Nikki Grace-Strader. I am the 2022 NAAOP Breece Fellow. I actually will be heading to Washington, D.C. day after tomorrow, and I'll be there through August 5th to participate in learning more about advocacy within, you know, the industry and really seeing how things come together at that level. I am an above knee amputee myself with osseointegration. I also am the director of North American Director of Operations for Osseointegration International. I'm a certified peer visitor and peer visitor trainer. I have a nonprofit in the state of Illinois, and I'm really passionate about advocacy and about, you know, opportunities for access to care for patients that are solution oriented. So I'm really excited about this summer. And just really grateful to get to be there. Want to thank the NAAOP members for being here today, and the non-members that attended, and invite you to, you know, look at the opportunity or explore becoming a member so that you can participate in more of these programs. Thank you very much.
Excellent. Thanks so much, Nikki. So that concludes our webinar for today. I did provide my email and the NAAOP website in the chat, as well as George Breece's email. So if anybody has any questions or wants to follow up about membership, please feel free to reach out. And with that, we'll end the webinar for today. Hope to see you on June 14th. Thanks, everyone.